Sounds good. Hello, welcome everyone. Thank you for joining Oxygen Therapy and Critical Care, the case-based series. Before we begin, we have a few reminders. For one, we will be using the chat function for all question and answer. To access the chat box, it's at the bottom of your screen. So if you have any questions, please send them through the chat and feel free to introduce yourself. If you have any challenges with audio or technology, send us a message through chat or WhatsApp, and we will be pleased to support you. And the session is being recorded, and your attendance is consent to being recorded, so thank you. So today we are on session 12. We will be discussing frequently asked questions and resources for oxygen therapy and critical care. This is our final session. We made it through 12 sessions over the last 6 months, so congratulations to the presenters for that. What we've done here is we administered a survey some months ago asking our network what are your most common questions and challenges in administering oxygen therapy and critical care, and we created the session accordingly. So we hope you find this valuable. As usual, we have the following presenters for the session: Dr. Francois Xavier, Madame Liberata, Dr. Joseph, Dr. Venuste, and Dr. Apollinaire. And with that, I will hand it over to Dr. Francois Xavier to get us started.
Yeah, thanks, Alana, for introduction. Today, as you said, is our last session among the 12 sessions you had over these 6 months. Before we start, just a small rule for today. It's like we are going to do a presentation of 60 minutes. We are trying to do for that. And as it is the last session for us, we will be having 30 minutes for the audience for the different questions they may have. We also may need some kind of discussion on course evaluation and feedback from the audience and other partners just in that 30 minutes. And we'll be discussing way forward about the certificates for whoever attended 9 out of 12 sessions, or other spokes whom attended and they didn't be able to finish their attendance because of internet interruptions and other reasons, but after the course maybe or the session, they go back and they read our material as we are sharing them with after each presentation. So we will see if we will consider the attendance or also the passing mark, the passing online exam. We may discuss with the partners how it can be done within the remaining 1 week, so that we can see the two criteria to whom we can deliver the certificates. So I invite the audience to come in as many as they can, so that the certificate will provide, they will get them according to either the presence, the attendance, or by passing the online exam. We will be discussing after the presentation after 60 minutes. So the audience today is yours, and we need your interaction. So we are going to discuss about frequently asked questions and the resources for oxygen therapy and critical care. It's a kind of revising from the first session to this last one. So today is like the question we are asking, we are giving you some discussion and the answers. But also the audience, I will be happy to hear from you for any question you may answer in the chat, what you think should be. As usual, next please. As usual, we are 4 co-panelists. Today, due to different reasons from different duties, we are having 2 co-panelists. We will have Dr. Venus and we have Dr. Joseph, but all questions here. There is a thread, I don't see Alana. Alana, the first slide before this. Can you slide the next? And okay, thank you very much. We are going to have two co-panelists, Dr. Joseph and Dr. Venus. But as teamwork, as a team, we'll try to cover all questions here on different slides. If the time allows, the audience also will be having time to intervene on some questions. And we are not clear, please feel free to ask for clarification. Next, please. Next. So this is now, let's start by Dr. Joseph, if he is allowed. He's going to help us to understand what are the indications of oxygen therapy and what is the purpose of oxygen therapy, the answer and discussion of the answer. Joseph, welcome. This is our last session. So I hope to be very warm discussion. Thank you, welcome.
So thank you, everyone. I hope you are hearing me very well, even it's raining. Am I right? Are you hearing me?
Yes.
Okay, thank you.
Yeah, hearing.
So, yeah, here we are in Butare. We are having a heavy rain for a short time. So, but no problem, we'll go through our presentations. So let's go back in our course from the session 1 till now, especially in oxygen therapy. So here most people are asking themselves what are the indications of oxygen therapy and what is the purpose of oxygen. So let's next slide. I'm sure here everyone can give the answer of those two questions. So let's go in our literature in our school and see the pathophysiology or a physiology of a normal cell respiration. So as you know, we got on our classroom, remember this image. I know most of people in secondary school, they know this image very well. So in case of a cellular respiration, four stage of cellular respiration. The first one is the glycolysis. So in the glycolysis, it's when you have a glucose molecule will create more ATP. So ATP is a kind of energy, and this energy from the glucose and the pyruvate and NADH. So those molecules become from the glucose. There's the one word, the glycolysis. And the second stage will be at the level of the mitochondria. This a part of the cell, really the center of the cell. So at this level, the pyruvate created in the first stage of glycolysis will be used to create what called acetyl-CoA. The acetyl-CoA is an enzyme and CO2. So and then the third stage, which is known very well, is Krebs cycle. Krebs cycle is where that molecule of acetyl-CoA will be used to create more energies, more CO2, ATPs, FADH2 and NADH. So then the last step, so it's a final step. So where the creation of more molecules, NADH, oxygen, FADH2, also creation of massive energy in matter of ATP and water. So as a summary of this cell respiration, not to bore you, just the cell respiration, the glucose is mixed with oxygen and they form carbon dioxide, CO2, and the water, and 30 or more ATP. ATP is a kind of energy which is being used by a cell. So next slide. So this is a kind of a summary of this image. So oxygen supplement precaution. Remember we told last time. So the extreme of hypoxemia. Remember, hypoxemia is a decreased level of oxygen in the blood, or hyperoxia. Hyperoxia is increased oxygen level in the blood. Both they have the potential harm to critically ill patient and also the outcome. It means low oxygen and higher oxygen, both really they're harming our patient. So oxygen is the treatment of hypoxemia, not for a short of breath or and oxygen has not been proven to have any consistent effect on the sensation of breathlessness in non-hypoxemic patients. So it means if a patient really it's not hypoxic, even he's in respiratory distress, really oxygen has not proven to help the patient. So if we remember the goal of supplement oxygen is to improve oxygen saturation and reduce the work of breathing. And remember the target of this SpO2 during oxygen administration for different patient condition. Every time when you give oxygen, remember your target depends on your patient. Next slide. Here we have other two questions. What are the optimal range, optimal target of oxygen therapy? And when should we give oxygen therapy? Should we titrate oxygen therapy? It means when we increase or decrease our oxygen concentration level to the patient. So let's get, so I hope here everyone even can give the answer. You know, you told last time in those presentation. Let's go the next to see how can we escalate our oxygen level to a patient, even for oxygen escalation pathway. So this escalation plan. Next. Okay. So this escalation plan will depend on heavily upon the resource you have in your hospital. And at each step, you will look at the patient rather than just the oxygen saturation number and adjust. Mean that don't treat numbers, just you treat a patient and see your patient is improving, just you decrease. Your patient is only not improving, you increase. If your device is not working, just you jump to another one. That's called escalation pathway. So pulse oximetry should be available in all clinical situations in which the oxygen is used. So remember that we said that the pulse oximeter is helping us really to titrate the oxygen we are giving. So SpO2 should be documented with other vital signs. You know, SpO2, it's a vital sign. Just document it during your assessment and you are making your plan. The approach to oxygen escalation and the target of SpO2 will vary by patient and the etiology of their disease process. So for example, in case of asthma or COPD, we give oxygen in the way different than maybe malaria or trauma and whatever. Just repeat the patient and condition would help you to know really what to do to a patient. So let's answer the next question on the next slide to see the target SpO2. So for example, in the case of COPD and other conditions associated with chronic respiratory failure, so it means those chronic obstructive lung disease. So you will administer oxygen if the SpO2 is less than 8%, because they are a chronic, kind of chronic hypoxia. And you will titrate your target to be between 88 to 92%. That's a normal SpO2 for those chronic condition for those people. So other conditions like trauma, malaria, whatever, just make make your target between 92 to 96. And then we will administer oxygen if the SpO2 on the room air is less than 92. It means really in other conditions, don't give a routine oxygen at 90%, 91, just give it when you are released. Then you will titrate to get a target of between 92 to 96%. Next, we are still on our oxygen escalation pathway. Next, please. Okay, so as I said previously, on this escalation pathway, we initiate the oxygen if SpO2 is below 94. So normally, and if the SpO2 is not available, it means we don't have a pulse oximeter. So we will consider empiric escalation of oxygen therapy for tachypnea or increased work of breath. So if you don't have values of SpO2, just use your clinic to make a decision so that you can start oxygen. So there's signs where a weak surrogate for SpO2 when titrating your oxygen therapy. Really, you can't say I'm 100% sure I'm giving a good number of oxygen if you don't have SpO2 values. So of course, we will start by delivering oxygen by using a nasal cannula. So remember that this nasal cannula can administer a flow of 1 to 6 liters by minute. If oxygen goals are not met, it means you are giving your nasal cannula, but really it's not helping your patient. So you will change from nasal cannula to a simple facial mask, which can administer 4 10 liters by minute as a flow. So also can use a facial mask at FiO2 of between 40 to 60%. So remember, in the previous presentation, we'll talk more time on that. So if oxygen goals are still not made, so you will shift to the non-breather facial mask with reservoir. And then remember, when you're using non-breather mask, don't go below 10 liters by minute. So otherwise, a CO2 will be retained in the mask. So let's go on the next slide. So here you remember very well this algorithm we took. Really, we got time on this one. So where initially, before your escalation, you have to assess patient. Remember, we said that don't treat number, just you treat a patient. So it means you do your physical exam, get your history, then after assessing your patient, you will see really if a patient is having emergency sign, or you will continue monitoring your patient and reassess if it means there's no emergency sign. So when really you see a patient there is an emergency sign, it means your patient need oxygen. So of course, really if it's really critically, you may consider intubation and start mechanical ventilation. It means, so here there is a list of emergency signs. Remember, kind of cyanosis is here, severe distress, shock, unconscious, acidosis, seizures, severe hypoxemia. So those are the features of emergency sign. So as I said before the previous slide, so if you decide to put your patient on the oxygen, you start by a nasal cannula. If it's not helping, you will use a simple facial mask. Also, if it's not helping your patient, you shift it to the non-breather mask with the reservoir. And then, of course, after you assess, if you are not helping your patient, remember you will go on the mechanical ventilation. It It means you can go on the mechanical ventilation immediately after seeing the patient is critically ill or having all those emergency signs. If not, you can go through this regular treatment, nasal cannula, simple facial mask, non-breather, and then the assessment. So really, remember you may not intubate your patient and you leave those devices and you start non-invasive pressure ventilation like a CPAP and BiPAP. So and then while using that, if we see our patients being gripped or not, remember make the assessment. If a patient is responding very well, you continue your oxygen therapy, then combine assessment until a patient is fully helped. Next slide. And you need to see on the next to see really how can take this escalation in therapy step by step. We told the previous slide. You start by a nasal cannula. If not working, you go on venturi mask. If not, you go on a breather. Of course, if not working, you go on high flow nasal cannula. If it's not working, you go on non-invasive. You choose a CPAP or BiPAP. So if you failed, you have no choice. You intubate the patient until they set a patient in ICU for close cardiovascular monitoring. Next, to see the next question. Okay, so the question is, what are the preferred device in administrating oxygen? So I think here everyone can answer this question. So next, to see the answer. Okay, so really it's important to know the oxygen supply capability at your hospital. It means just you need to use what you have. Don't think we need material from everywhere, to transfer to do it. Just use what you have. Then remember the consumption rate for different delivery devices. So if you don't have one nasal cannula, you don't have what, really it's really hard in our settings. So depending on the facility, oxygen supply type, some oxygen delivery device might not be practical. For example, I'm sure in most of DH, they don't, you don't have venturi. So maybe also you don't have those CPAP machine, probably. So, but it means here you use what you have in your settings. So let's go to the next slide to see those devices. So this is the nasal cannula I told you before. You can use it for 1 to 6 liters per minute of flow. You can use it. So if not working, you can go simple facial mask. So which can give you a flow from 6 to 10 liters per minute. So, and if not working, you can go on non-breather mask, which is having a reservoir. So that can give you between 10 to 20. So those are the simple material which are really in all our hospital, maybe not health center, but DH, provincial hospital, referral hospital, really, we can't miss those material. Just remember to be familiar with them and use them by escalating them on treating a patient. So let's go the next to see the method. So what are the different methods of oxygen therapy? So in the answer, next slide, the method of oxygen therapy, really, they can be considered in several ways. Of course, source of oxygen, what you have, a cylinder, concentrator plant, or liquid tank. So delivery of oxygen, is it invasive or non-invasive? So remember, when we say non-invasive, it means we never know, we are not entering the patient body. That's why you would superficial. When invasive, it means we are in, but they were in the patient land, so that they're doing a mechanical. So of course, because that the flow of oxygen, maybe you are low flow or high flow. And then, of course, you have to assess your patient. Then when you prescribe the oxygen, remember you need to precise your target, your oxygen target. Of course, the monitoring and the maintenance of target saturation. Then you plan your weaning and discontinuation of oxygen therapy. Really, it means plan your weaning process on your patient. So let's go the next to continue with the method of oxygen therapy. So where I say you assess your patient and then you document your target oxygen prescription. Of course, you use the device to be used, and then you recommend to a monitoring and maintenance of your target saturation. Then you plan your weaning therapy. So next slide. So really this is to show us how we can choose our best method, and how we can closely monitoring and follow our patient if a patient is on oxygen. So remember, if you put a patient on oxygen, you will need really a close monitoring to see if you are helping your patient. So the first, you will ask yourself if your patient is critically ill. So if a patient is really critically ill, so you will start by oxygen administration. If it's a critical ill, you start by 15 liters by minute of oxygen, of course, by using a simple mask. Just don't start by nasal canal on the patient really who is critically ill. So, and then if a patient is not critically ill, so you ask if your patient is at risk of hypercapnic respiratory failure. So remember this, we discussed it in the previous sessions. This is type 2 respiratory failure. So if a patient is having a type 2 respiratory failure, so you will target your saturation. It will be between 88 to 92% or level of your alert card whilst awaiting blood gas and that. Of course, your patient really is not critically ill, but it's a high risk of having a hypercapnia. Just you measure your, if of course, if you have your ABG machine, you will measure the blood gases. So you will give between 24%. It means using a nasal cannula giving oxygen to a patient because it's not really critically ill. And then if you go to your ABGs and you find your pH is above 7.35, it means it's not acidotic patient. It means alkalotic. So you will treat with Venturi or use a nasal cannula, you give a low flow oxygen. So but your patient is acidotic, it means pH is below 7.35, and the PCO2 is above 6. It means respiratory acidotic. So really, you will need an emergency intervention from your senior, because this patient is at high risk of having a respiratory failure. Even initially the patient was not critically ill, but you go to our ABGs, this patient is really at high risk of getting respiratory failure. So if a patient is at high risk of getting respiratory failure, but really you see there's no features of risk of hypocapnia, so really that patient need a high SpO2, you should target from 94 to 98 because really the patient who is somehow kind of safe. And then when the SpO2 is below 94 on a room air or oxygen, if requiring oxygen to achieve above the target, it means above 94 to 99%. If you see really is below 94 and you go to your ABG, if a patient is still acidotic, of course you will contact your senior. It means or acidotic patient, please, you will need help from a senior. So if a patient really is not in acidotic, you will titrate oxygen to maintain a target range between 94 to 98, as we said before. So if a patient is not a SpO2, it's normal, it means above 94, really, you monitor the patient and really not really required to get the oxygen. So let's go to the next question to see the possible complication of oxygen. Here, toxicity, it means oxygen excess, administration and prolonged oxygen use. So really, it's harmful, as we said before. It's dangerous to give a patient excess of oxygen or make a patient prolonged on oxygen. So really, toxicity of oxygen. The oxygen therapy can lead to retinopathy of prematurity in a neonate. You know this one, if you're working in neonatology, you know, sometimes, you know, we those neonate, the toxicity, the first thing is retinopathy. So hyperoxia also can lead to oxidative stress through the body. So this is why we monitor SpO2 frequently to adjust the flow of oxygen. So we don't target 100% of SpO2 because this really it's harmful to our patient. So then we need to wean our patient from oxygen as soon as possible. They are improving. At the target FiO2 of oxygen to decrease above below 60%. So let's see on the next slide to see what danger you can get from the hyperoxia. So where can those induced hypercapnia, so where we can get, where it can goes iron, superoxide, hydrogen peroxide. So all of those can give reactive oxygen species. And they are dangerous and can lead to cellular injuries. So when your cell is injured, it will produce any systemic inflammatory process. Of course, these hyperoxia also can lead to vasoconstriction. Of course, as I said, retinopathy in the case of hyperoxia really is done. So at the level of lungs, this hyperoxia can produce really a kind of a direct effect of atelectasis. So really, those some effect which can be manifested on hyperoxia on different organ, lungs, the heart, vessels, and cells, even on the brain, and the eyes, where can get a retinopathy. So let's go to the next slide. We talk about hyperoxia. So of course, as I said before, a cellular injury, this hyperoxia can produce a cellular injury through increased production of lactic oxygen intermediate, those superoxide anion, hydrogen peroxide, and those radical of hydroxide. So those free radicals, they will react with and impair the function of essential intracellular macromolecule, resulting in cell death, and promote the deleterious inflammatory response, which will lead to a secondary tissues damage or apoptosis. So there is hyperoxia and you said lung injury. So this is not common, but it's happened when you give a lot of patients for a long time, where hyperoxia will increase a susceptibility to mucus plug, lung atelectasis, and secondary infection by impairing both mucociliary clearance and bacteria capacity of immune cells. You know, those mucociliary, they are a kind of barrier so that bacteria not entering our blood easily. So let's see the next slide to see advantage and disadvantage of high flow. So remember, when you give a high flow a patient, really, it means you are giving really use those devices like high flow nasal cannula. So as the answer, high flow oxygen therapy. Next slide. So the advantage are that in the case of normal adults, their breath at flow between to 20 to 30 liter per minute. This is a kind of a normal flow. So patient in respiratory distress breathe at higher flow. Of course, they need more oxygen. So high flow oxygen therapy require a special machine to generate a flow that are greater than the normal flow. The high flow oxygen therapy, it requires a specialized nasal cannula or plug device. It means it's not every single device can give high flow. So then the high flow oxygen therapy will require heat and humidification. This will decrease the mucous membrane, the membrane irritation and dryness, so that it can harm our patient. So high flow oxygen therapy really does not assist with ventilation, especially for CO2 clearance. This CO2 need to be cleared. It means the CO2 out. CO2 out. These are high flow. They don't need assist with mechanical ventilation. So let's go to the next slide to see the disadvantage of this high flow machine. So most patients tolerate oxygen delivery via high flow nasal cannula. So some contraindication or complication are rare in adult. So really here you need to set the flow rate and your targeted FiO2. So then the clinical benefit, really, this is small and is pliable nasal prong. It means it's a kind of a nasal prong. And warming and humidification of secretion, then washout of nasopharyngeal dead space. Of course, it will provide a continuous positive airway pressure in your respiration, and then it will give high flow rate. Of course, the big benefit is to decrease an inspiratory effort for your patient. So thank you. I'm done with answering those questions. I'm still here. Then if someone can add comment, just you will tap in the chat box. Thank you.
Yeah, thanks, Dr. Joseph. Thanks for your presentation. I hope in the audience you are now getting clear about clarification about oxygen therapy, and I hope this will help you in the center or hospital. Please don't use too much oxygen where it's not needed, and don't use less oxygen where we need too much oxygen. As you know, all of you, we are coming from the COVID period. Allow me to invite Dr. Venus to come and present to us about COVID-19 management in oxygen therapy. Dr. Venus, welcome.
Thank you very much, Dr. Xavier and Dr. Hello? Do you hear me?
Yes, we can hear you.
Yes, the next slides, we are going to discuss questions regarding COVID-19 patients and how we can supply them with oxygen. So the first question is, how do we treat severely hypoxic COVID-19 patients? Let's see the next slide. Can we go? Yes. So generally, when you are having is to classify your patient in the risk stratification from asymptomatic to critical. And in a patient who is having COVID-19 without hypoxemia or risk factors for severe disease, you want to treat them supportively. You treat the symptoms. If they have fever, you provide antipyretics. If they appear dehydrated, you treat dehydration, and you take into consideration their past medical history. If they have any medical condition or other pathology, you have to treat it. Then when they have COVID-19 but without hypoxemia or radiological evidence of disease, like the viral pneumonia, but when they have risk factors for severe disease, including age above 60 and cardiovascular disease like cardiomyopathies, ischemic heart disease, if they have hypertension or diabetes, COPD, malignancy, immunosuppressive condition like uncontrolled HIV, evidenced by raw CD4 below 200 cells. When they have malnutrition, pregnancy, or tuberculosis, you need to admit them and provide symptomatic treatment. But also there are two other things you need to consider. And one is giving monoclonal antibodies if they are indicated, or you give antiviral to prevent the replication of the virus. So for the monoclonal antibodies, we mainly provide them to patients who are above 12 years and who weighs above 40 kilograms of weight. And there are a number of different antivirals you can use to stop the replication or the transcription of this virus. One is ritonavir boosted with nirmatrelvir, and the other antivirus you can use is molnupiravir. And of course, these antivirals and monoclonal antibodies, they can have adverse effects on the kidneys, on the liver, so you need to monitor your patients. So generally for patients who require oxygen, they need supportive treatment, but also mandatory, they should get steroids. And among the steroids you can use dexamethasone, hydrocortisone, methylprednisolone, but you can also use prednisolone. So for the dexamethasone, you can use 6 milligram IV or peros once per day, and you give it for 10 days. Any of the steroids you choose, you have to give it for 10 days, as the different studies have shown that they decrease the mortality rate at around 28 days when they are taking these steroids. So don't forget to give steroids when the patient is hypoxic. You can also consider this antiviral remdesivir. You can give monoclonal antibodies as well, tocilizumab or baricitinib. But you may also consider other medications that are being considered in a clinical trial at a site. So if there is a clinical trial on using, let's say, interleukin molecules to address COVID-19, you may consider giving them to the patient. And the next slide is for critical COVID-19 patients. Let's see what we can do on the next slide for patients who have critical COVID-19. Next slide. Yes, for those who are critical or they have ARDS, of course, in every patient, you need to provide symptomatic treatment. You may consider empirical antibiotics in a critical COVID-19 patients. And they may be in shock, either from bacterial spike infection, and you need to give third generation cephalosporin like ceftriaxone and azithromycin or doxycycline. And you give corticosteroids as in any patient who is having hypoxia or hypoxemia. Then you give you may give anticoagulation for DVT prophylaxis. And patients who are requiring admission within 24 hours, you may give tocilizumab. Sorry. But for patients who are requiring mechanical ventilation, you have to avoid remdesivir, as patients do worse if they get this antiviral. Next slide. So regarding how many liters of oxygen that you need to give for COVID-19 patients, let's see on the next slide. So you generally need to give oxygen, as you have seen from the previous slides. In the general population, when they are desaturating below 92, you need to support them with oxygen. But for patients who are having like COPD or other obstructive pulmonary disease, you supplement them with oxygen when they desaturate below 88%. So you start with the nasal cannula for mild to moderate COVID disease, and you can titrate up the oxygen from 1 liter to 6 liters. And the maximum FiO2 you can give with nasal cannula 6 liters, it's 50%. For moderate to severe disease, if the nasal cannula is not working or helping you to reach your targets, you can move up to a simple mask from 5 to 10 liters. And if, of course, you can't achieve your targets with the simple mask, you move up to a mask with a reservoir. And with this, you can give from 10 liters to 15 liters. And of course, for severe disease, very severe disease, those who have ARDS, they need a positive pressure to recruit the lung, which is at the collapsed alveoli. And you can achieve it either by using a high flow nasal cannula, or you use a CPAP or BiPAP. So there are advantage of nasal cannula to a mask with a receiver. So they are widely available in many health facilities, and they are simple to use. And some of the disadvantage is that the masks prevent the patients from eating and drinking. So there are multiple interruptions if you are going to feed, if you compare to the nasal cannula. So when you are using a mask with a receiver, you need to give from 10 to 15 liters. If you go below 10, the patients may rebreathe the CO2. And this mask, they can also cause dryness of the airways. So that's why you need humidified oxygen. So for very severe patients where you have you are delivering a positive pressure with high flow or CPAP, you can give a precisely predicted or set FiO2. And the disadvantage is that they are blowing with a high pressure, and they have aerosol component, and it can be a barrier for infection prevention, and you can spread the infection if you have too many patients in a single room. But also you can contaminate the surfaces. So you can also use a Venturi mask, and this one is preferred for patients who are having or who are suspected to have type 2 respiratory failure. So remember from the previous sessions, it's hypercapnic respiratory failure where the ventilation is a problem and you can't exhale completely the CO2 produced in the gas exchange. And you can also use this non-invasive ventilation, of course, the CPAP or BiPAP. Let's see the next question. How is the oxygen administered using the Venturi face mask, and what is the role of this device in the management of COVID-19? So you can see this mask has different valves, and each is delivering a precise or presetted FiO2. So let's see the answers and discuss them on how the Venturi face mask is used to deliver oxygen. Next slide. So for patients who are having or who have COVID, but also they have other conditions that might cause type 2 respiratory failure, you want to choose this Venturi face mask, and you can start with 2 to 3 liters and see how your patient does. And if the patient is not improving, you can go up to 4 to 6 liters to increase the inspired FiO2 to 28%. But if your patient is not doing well or reaching your targets on 4 to 6 liters, you can go to 8 to 12 liters and reassess afterwards. And with the Venturi face mask, you can go up to 15 liters flow rate per minute. And with that flow rate, your inspired FiO2 is around 40%. So, and here we're having signs we can based on to see if your patient is not doing well in any of the device you are using to deliver oxygen. So you can consider your patient is respiratory-wise deteriorating if the respiratory rate is increasing, especially when it reaches above 30. You need to consider calling your senior or the ICU support team, consider mechanical ventilation for the imminent respiratory failure. So if your SpO2 is decreasing as well, the respiratory deterioration is settling. And oxygen, if you are requiring high oxygen, like moving up or titrating up, your patient is deteriorating. And if you are also having increase in the trigger score or the score we saw for detecting a critically sick patient, the national early warning signs, if they are up on the calculator or the score, you need to consider that your patient is deteriorating and move to another level of oxygen support. So there are other signs you can based on to say your patient is retaining CO2 if they have like drowsiness, if they are complaining of headache, if they have flushed face or flapping tremors. You have to seek for help. You call for help either from the HDU or the ICU support team. Let's go to the next slide. So how the non-invasive positive pressure ventilation is used in the management of COVID-19. So we have seen that the CPAP functions physically the same as the BiPAP, except that for the CPAP you have a set constant delivered pressure, but for the BiPAP you have two different pressures. High pressure, the patient is inhaling, and the less pressure when the patient is exhaling, but they are basically the same. Next slide. So this non-invasive positive pressure ventilation can help you avoid intubation if you are in a center where having the ventilator machine is a problem. You can rely on this non-invasive positive pressure ventilation, and your patients who are going to likely benefit from non-invasive positive pressure ventilation are patients who are having COVID with either COPD or obstructive sleep apnea, or they have pulmonary. Those ones they are likely to respond when they are put on CPAP or BiPAP. So your patients on non-invasive positive pressure ventilation, they need to be closely monitored, as the high tidal volumes or work of breathing may risk the patient-induced lung injury, ARDS. And you have to ensure that the masks are fitting well on the patient and there is no air leak. And you have to prefer mask, a full mask, rather than prolonged use of non-invasive positive pressure ventilation is linked with malnutrition, as there is a tendency to not interrupt this continuous delivery of pressure and to feed your patients. Generally, you will prefer this method of oxygen supplement if you judge it's going to be for a short period. But for a patient who is likely to require this mode of oxygen support for more than 48 hours, you can consider intubating them or support them with a facial mask with non-receiver, but if it's helping you to reach your targets. So with this this mode of ventilating your patient, there is a risk of aerosol with contamination of the environment, but also the patients close to the one you are supporting. Let's see the next slide. Next slide. Yes, we have seen the indication for preferring positive pressure ventilation. Let me call you, there are patients who are having COVID-19, but they also have like obstructive sleep apnea, COPD, or pulmonary edema, or those who are at risk of type 2 respiratory failure. And you want to avoid or delivering oxygen using this non-invasive positive pressure ventilation for patients who are going to require the CPAP or BiPAP for a long period, like more than 48 hours. So there are some contraindication, like patients who have like esophageal or gastric surgery, patients who have upper GI bleeding, patients who have facial traumas or neurological surgery, or they have significant facial deformities, or they have airway obstruction, either from a tracheal tumor or a laryngeal mass. And generally, patients who are not going to cooperate, like they have altered mental status, we are not going to put them on CPAP or BiPAP. Next slide. So there are two slides of my presentation. I'm going to address the adverse effects of positive pressure ventilation in COVID-19 patients. Let's see the physical and biological compromise of this positive pressure ventilation in COVID-19 patients. So for a patient who is receiving a low, patients ventilating at low lung volumes, during end expiration, they have a kind of atelectasis. Their lungs, the alveoli are collapsing, and at the end of inspiration, there is a minimal distension of the alveoli, but it's not going to be enough to recruit the lung for better gas exchange. So when you are delivering high volume, high lung volume, like you are using a CPAP or you are using endotracheal tube, so there is over distension of alveoli, and you can have air leaks. And this air leaks, there can be a cause of the barotrauma leading to either pneumomediastinum, pneumothorax, but also subcutaneous emphysema. There are structural consequences as well if your patients are constantly exposed to high lung volumes. And one is a destruction of epithelium, but also when this epithelium is destroyed, the clearance of or the mucociliary function is lost, but also the surfactant production is also impaired, and you start to have fibrous tissue proliferation, and you have hyaline membrane deposition. You have pulmonary edema, most likely from increased alveolar capillary membrane permeability. And this is going to cause a decrease in physiological dead space. The space involved in the gas exchange is going to reduce. It's going to increase, sorry. Let's see the next slide. So we came to see the structural or consequences of constant high positive pressure, but also the barotrauma or the volume, the effect of the high volume in the lung causing the over distension and the air leaks. So the next slide is going to show us the biological compromise or the biological alteration of the normal lung parenchyma. So with this constant delivery of positive pressure, so there is increased concentration of inflammatory mediators, and we have transforming growth factors, interleukin-8, we have tumor necrotizing factors, interleukin-6, 1 beta, and we also have recruitment of pulmonary alveolar macrophages at the site, but also neutrophils. And we have activation of epithelium and endothelium at that place as well. And generally, this recruitment of macrophages, neutrophils, and inflammatory mediators, they are going to cause systemic effects like causing systemic vasodilation, and you may also have increased apoptosis of cells at the site of macrophage recruitment. Different these mechanisms at distant organ sites, you can have organ dysfunction, and the organ dysfunction is going to cause cell death, or you are going to lose the patients from all the interaction of this mechanism. Let's see. So the next presenter is going to address a question regarding ARDS management and the strategies for ventilation.
Thanks, Dr. Venus, for the presentation.
Thank you very much. Thank you.
Thank you very much for the presentation to remind us how to manage COVID-19 and how to use this non-invasive positive pressure ventilation. To the audience, as you see, we are in oxygen therapy series. Oxygen, as other drugs, has to be prescribed to be given the correct dose. Otherwise, you see there are too much complication about oxygen use, depending also on oxygen amount and oxygen route, oxygen or device you are using. As Dr. Venus presented now, you see how the lung will be damaged biologically, structurally, and all of those are effect of oxygen if you use it in incorrect way. So COVID is leading to ARDS, but without COVID also you can get ARDS. We are not going to go into definitions, but how do we manage them once diagnosed, and which are ventilator strategies are preferred? In one word, next please. The ARDS, as we defined in the last presentations, I think session 8 or 9, is a life-threatening form of respiratory failure, which is characterized by inflammatory pulmonary edema. Inflammatory pulmonary edema resulting in severe hypoxemia. Here, as you see, there is inflammatory pulmonary edema leading to severe hypoxemia, which of course we need the oxygen as the first drug to give in this case. Research has focused and adjunction measures aiming at mitigating the ventilator-induced lung injury, because as Dr. Venus presented, the above complication of non-invasive positive pressure ventilation are also maybe called also ventilator-induced lung injury if the patient reached also to be on the ventilator in the invasive way. So by this research, what are ventilator strategies to reduce this ventilator in this lung injury? And next, please. Next. Generally, the management of ARDS on ventilator strategies and adjunctive measures, we have to understand that the mechanical ventilation in ARDS, we have to use low tidal volume ventilation and inspiratory pressure. Because if you use a high tidal volume, you remember with ARDS, there are some alveoli which are damaged. If you have the normal lung has, for example, like 500 milliliter, you are going to give the 500 milliliter in this patient where you may have like 300. Sorry, if the normal lung should contain 500 milliliters, and in ARDS patients, you are going to give the same amount of that volume. The patient alveoli to contain that volume some of them has been damaged and they are no longer viable to contain that volume. The reason why, if you give it too much, you are going too much a complication rather than treating the patient. Reason why we are going to use low tidal volume and high PEEP. We will see and high PEEP because that high PEEP will maintain the alveoli open. That is one. Second, you can use also the proning position. We discussed it in the previous sessions, how we do it. And also the high frequency oscillatory ventilation, which we don't have in our settings around here in our country. And in ARDS, high PEEP compared to the lower, because as you are giving the low tidal volume, you may need that high PEEP so that the alveoli, which is flowing into that fluids in pulmonary edema, are kept open, and the distance in between the vascula is reduced so that the gas exchange can happen with that high PEEP. Also, there are these recruitment maneuvers. The recruitment maneuvers is a kind of recruiting the viable alveoli in ARDS cases so that you open them in a short time, and again you maintain the movement of recruiting and increasing the gas exchange, decreasing the gas exchange distance by increasing also the gas exchange chance in that status of flooding of fluids. There is also another extracorporeal membrane oxygenation, which we are not seeing in our country here, but with the developments, we hope soon to have it as critical care fellowship will be soon introduced. Other thing we have to remember that to sedate a patient so that the patient is not fighting with the ventilator. As you remember the COVID cases. As Julienne, Julienne, can you? Oh, thank you. So as we said, and as we experienced our COVID cases, our COVID patients, they get intubated and put on a machine. Sometimes the time they're fighting on the machine, you need to sedate them. And then you were using neuromuscular block agents. These are kind of 6, 7, even to 10 method that of managing a COVID case without increasing the ventilator associated lung injury by combining this kind of package in managing a COVID from either the COVID-19 or other infection which can cause other cause which can lead to ARDS. Next, please. Next. So how is the critical care provided outside the ICU? This is really a very interesting question. With you as my colleague and my counterparts, we are working in remote settings where we can have, or we are the first counter of critical cases. And how can we have a kind of critical care management at our remote area where you are, in that place where you are sitting now? How can you have a setting of critical care if a case comes? So the development of critical illness really occur without warning, meaning there is a warning of that patient, and when you are not detecting the warning signs, the case will be in critical. Once that is in critical, what are you doing there? So we are recommending you, we are encouraging you early detection, early recognition of a critical case, so that you start to think what will be to escalate the plan from your low setting, health center, health post, hospital, district hospital, and what will be the management plan of your critically ill patients, and you think to the tertiary level for referral. So when signs of deterioration are noticed, there is often no system in place to direct for the next step, and the patient may be left waiting. This, I think, is the experience of most of us. You have a critical case, and if you are not organized to your place where you are, you can feel like you are ashamed having a critical patient to you, but nothing can help him because of either by the system not organized to manage such case, or there is many factors which may challenge you to transfer the patient on other time, and the patient will wait there. At the end, when you transfer the patient, is almost at the end of life. So the critical illness needed to be seen as a continuum of care. What this here means is a continuous sequence of interlinked events from the very early moment of the illness, from home. So we have to do education of our communities, when to see consultation in early time, and then when they arrive to our raw settings, to think about this critical illness on early time, and think for ahead what will be like a management plan of such critical cases. So the continuum is manages or is into pre-ICU intensive care unit, which may be the former one or the one you can organize in your units. With the current hospital accreditation process in the country, we are encouraging people to have like essential emergency and critical care equipment and supplies and drugs. So I hope by this 12 session course on oxygen therapy, you had already organized such place where you can manage a critical case, to start from there and then end up by either a referral hospital and give a chance of survival. Next, please. Next. So the critical care, as we said, is a continuum. And as you have to understand, this critical care is time critical care. The meaning here, the keyword is time critical. The time is the corner of the survival of this critical patient. And if you receive such patient and you don't have this early detection and early intervention in such case, the disease will progress, will worsen, and the patient will be, the outcome of the patient, the survival rate will be decreasing. So that from this time, as we are saying, this time critical, you have to consider it in the place where you are, and then before thinking about referrals. The critical care capacity has been neglected globally, and locally also, let's say so, due to different factors, organizational or staff, also capacity building. Reason why we had to have this online course, and which I think may continue even after this, when COVID will be over in the coming month. There is a global need for essential emergency and critical care, and I think to your setting, you are trying to organize how you can do emergency services and critical care services as we are moving to hospital and health center accreditation. So this is kind of a continuum of that critical care from SAMU, which we call EMS, to the ER, emergency room or the floor, in ICU, the former ICU, and back on the floor. When you say back on ICU and the floor, mean that either surgical ward, internal medicine, whatever they are doing a kind of a follow-up on monitoring after the critical has been sorted out. And then home and the rehabilitation, where we will need to discharge in planning and what the patient has to do at the home, the follow-up to be done after discharge from your clinic. Next, please. How are airway managed in critically ill patients? This also is a very crucial and a good question you have as the audience to think about. Airways is really important. As we discussed in previous session, how do we get oxygen into our lungs? Is via the environment. Then through the airways, you get oxygen into lungs. And in lungs, then there is exchange, and the lungs goes into blood and into the tissue for use. So if the airways are not well managed, meaning that the way to go, the air to go will be obstructed, they will not, the patient will become hypoxemic. And in such case, as we see here, in hypoxemic case, you need to give oxygen via nasocannula, facial mask on a breather. But remember, if airways are obstructed, try to clear them so that the oxygen you are giving will have a way to go through and reach the alveoli. If there is hypocapnia, also oxygen ventilation can help. I will not be in details of which device you can use because everyone in this audience or box, we know how oxygen delivery is delivered by different methods, as we discussed in previous questions, how much oxygen you have to give and which oxygen device you have to reach till to the intubation, etc., etc. Increase the work of breathing also, as we said, is not a sensitive signs of hypoxemia, but if you don't have oxygen pulse oximeter, please give oxygen in such case. Airway obstruction, as I discussed, try to give oxygen, open airway with the possibility of intubation. This is in general airway management in critically patient. Try to open those airways, give oxygen by one or another mean, as we discussed from different oxygen delivery devices. Next, please. Is minimizing respiratory distress or respiratory failure? There are steps. Steps are the same. Is recognition of clinical sign and knowing which intervention, equipment you may need, provider. In this case, when you are saying on step one, recognize the clinical sign, apply oxygen and pulse oximetry, and call for help and inform the medical doctor. Oxygen, deliver oxygen with oxygen delivery devices and appropriate oxygen flow you are giving. Any registered nurse, whoever can administer oxygen, please, you call for help, you give oxygen, and then the medical doctor come when you already had an intervention in such respiratory distress, respiratory failure. Dr. Joseph described to you how we get oxygen, and in the mitochondria, how the oxygen are being used with the glucose to get energy. If there is no oxygen, the glucose will not be consumed, so that you will not have that energy. We will end up by acidic fields where cells will die because of what? Missing oxygen. So being a nurse or not, don't wait a medical doctor to come prescribe oxygen, give oxygen, the doctor will come to complete you. If the inadequate breathing is the same, open airway, give oxygen. If unable to ventilate with bag valve mask, you consider subglottic. This is the advanced airway management. I will not be in details for our folks and the audience now. Maybe we'll discuss it later when we will be showing you what is this kind of subglottic airways. Next, please. How do you address multiple emergencies? How do you address multiple emergencies? This is also a complicated question, but everyone, this audience can answer on it. The answer is simple. Next, please. The answer is simple. We are encouraging you to use existing protocols and the guidelines. For each emergency, which steps you have to follow, please try to have those protocols and the guidelines for each of emergency you are encountering in your experience in your service. If you don't have, call for help, try to have it. You can use those from WHO, from Ministry of Health, or in any other protocol or guideline can help you to manage any emergency you are having. Which emergencies do you account in your setting? You can list them, and then we can provide or we can search for protocols or guidelines. Next, please. With those protocols, as we are saying, you have to do to know identification of the critically ill patient. And with this identification of the critically ill patient, times the essential care of the critically ill, this means what? You identify the patient, you are managing the patient on the early time, early intervention. And this will be needing what? So we'll be needing parameters of hospital readiness to manage the critical case. Also clinical practice. This clinical practice, the way you are managing cases, as I'm saying above, following those protocols and the guidelines, hospital readiness, essential care will lead to effective coverage of essential, emergency, and critical care. And at the end, the stabilization of the critically ill patients, which will give the chance and the probability of increased survival of the critically ill in the setting where you are. So there is here elements you have to consider: your facility readiness, your clinical practice, and how you do identify critical case. And once you identify it, what do you do and how do you do it? All of these elements will help you or will help our patients to increase their survival and are discharged from hospital happy they go home. Next, please. Here there is a last question: how do you manage the sedation and choose medication for patients who require prolonged sedation? These are cases when you are working in ICU, patients are sedated, and you need to give them sedation. Also, we will not need too much comment about this because most of our setting facility where we are, I think you may have need to sedate a patient, but not this kind of prolonged sedation on mechanical ventilation. The answer is one, as the next please. The answer again is to know which kind of medication you have to use for which purpose. Next please. For which purpose? So there is a clinical practice guideline for prevention and management of pain, agitation, sedation, delirium, immobility, and sleep disruption in adult patients in ICU. This we are typically talking about ICU cases. Reason why, if you are having such case, you can visit this online article and will help you to step by step, case by case, managing pain, agitation, delirium, etc., etc. But for now, let us focus on organization of our critical care outside this formal ICU and have all material you will need in terms of oxygen, in terms of emergency drugs, essential equipment, etc. Next, please. Yeah. Let me use this Nelson Mandela statement, who is saying that the education is the most powerful weapon which you can use to change the world. This is our last session of oxygen series and the critical care. I hope every one of you now at your respective facilities, you know the need of oxygen, the importance of oxygen, which devices you may need to help the patient. Those patients are our parents, our relatives. And then which kind of devices you use, how much oxygen, complication of oxygen. So by the end of this slide, I think the 12 session you had together helped you to understand what are oxygen series, how can we manage critical cases, and I hope, next please, next, as we tried to answer almost this more than 25 questions, we are going to organize an online exam from now to next Wednesday, so that whoever needs a certificate and who didn't have a chance to attend physically the actual session, but after the presentation maybe had the time to go and read through our materials, it will be a time to know whoever tried to understand the objective of our online course. And if you meet the pass mark, yeah, I think you will be also eligible for the certificate. Otherwise, whoever attended 9 out of 12 session is eligible for session for the 30 CPD and certificate, a general certificate. I think certificate of completion of this 12 session on online course. And let me thank you again. And next, please. Next. Next. Yeah, and the spokes and audience, if you allow us, it's your time for some kind of feedback, either in the chat, comments, or questions, because the last time I had some people who didn't get their certificate. Now this is time to say to tell us your challenges you had, so that you will address them by, as we said, by the next 2 weeks. Thank you very much, and that is the end of today's presentation. But it's the time of the audience to give us a challenge in the as a feedback for improving our course in the coming days, coming programs. Thank you. So to our partners, I think you can allow us some minutes so that the audience feel free to interact and tell us how can we improve our online course in different programs we may have in the future. Thank you.
Dr. Francois, it looks like you've just finished your presentation. Sorry, I had to step out, but just wanted to say thank you so much for all of your hard work in delivering these sessions and organizing them over the last several months. You've done such a wonderful job, and thank you to all of our participants for calling in every 2 weeks and being committed to learning and refreshing your knowledge. Just to answer the question in the chat, we are looking at on the Assist International side for additional opportunities to continue our programming. So we're actively looking for funding and all of that, so that hopefully we can, all convene again together in the near future. And everyone on the list in attendance today should be on our mailing list, and so we'll definitely be letting all of you know if that is the case. In terms of certificates, we will be providing them in the next 2 weeks for level 3 CPD. There's been about 2 or 3 people who've messaged me just in the last hour about their certificates. They've all received theirs now. So if you're also in a situation where you didn't receive a certificate, but you filled out a form, just message the WhatsApp group. Sometimes there's a typo in your email or in your name, and there's some sort of problem there, but otherwise we should be up to date. So thank you again, and I'll hope to see all of you again soon.
Thank you very much for your support, Alana and the team. Thanks to the spokes and the audience really for their time, 2 hours every 2 weeks. Together with their job, their task. I am really appreciating the attendance, I'm appreciating the interesting attending, and also the topic was very, very relevant to our setting, as you will remember this COVID period, but also I think out of COVID also oxygen is needed. Thanks for the support, and we are hoping to be together even if the time allows in the coming programs with Assist and with the colleagues. Thank you very much, Alana and the team. Yeah, done.